I will present you different imaging studies that I performed during my PhD thesis at the Center for Small Animal Imaging in Orléans. The first example is a bimodal method to assess early changes of intratumoral oxygenation, photoacoustic imaging coupled with oxygen partial pressure measurements. Regarding background, as many of you already know, hypoxia commonly occurs in solid tumors from various origins due to an uncontrolled proliferation and an insufficient neovascularization. It's responsible for tumor resistance to radiation therapy and chemotherapy. The aim of this study was to assess tumor oxygenation thanks to two different modalities to validate a non-invasive imaging measurements of tumor hypoxia. We used the Vevo LAZR system to obtain the in vivo quantification of hemoglobin saturation, the SO2, and the OxyLite system to obtain the in vivo quantification of oxygen partial pressure, the PO2, with invasive probes. So we used this system to simultaneously compare the SO2 and PO2 in a mouse model of breast carcinoma. This model was a 41 model of breast cancer, orthotopically implanted in mice. Tumor volumes were assessed by 3D ultrasound, and tumor oxygenation was monitored by both photoacoustic imaging and two probes from the OxyLite system. The first probe was inserted in a muscle in order to have a reference, and the second one was inserted inside the hypoxic core of the tumor. These are results you can obtain with the Vevo LAZR. You have here the subcutaneous tumor, and here the tumor with well-oxygenated area of the tumor in red, and the hypoxic core of the tumor. And we can measure the hypoxic volume inside the whole tumor volume. We control the position of the OxyLite probe thanks to ultrasound. As you can see here, the OxyLite probe is inserted inside the tumor, and you can control the position in an hypoxic area of this probe. And after the PO2 probe stabilization, we recorded dynamically in real time the photoacoustic and the OxyLite parameters for 10 minutes. In order to compare these two different modalities, it required to perform an oxygenation challenge from 100% of oxygen to 5% of oxygen, and then back to 100% of oxygen. For this example, you can see here the muscle, and here is the tumor. We draw this region of interest on the muscle as a reference, and this is the whole tumor, and the blue area dedicated to the hypoxic core of the tumor. On this dynamic acquisition, you can see the oxygenation becoming lower in blue, and then back to the red color, becoming high with a higher oxygenation. These are the results of the two different modalities. From the Vevo LAZR, you can see here the SO2 of the tumor becoming decreasing when we were changing the oxygen to 5%. We have a decrease, then an increase in the SO2 for this reference. And we observed the same changes in the partial pressure measurements measured with the OxyLite system, and back to the normal also. Regarding the tumor, we have smaller changes in tumor oxygenation. And for the hypoxic area inside the tumor, we don't have any changes in tumor SO2 as compared to the probe inserted inside the hypoxic area with OxyLite system. So no variations were detected in the hypoxic core of the tumor. So we observed these oxygenation variations by both modalities, and there is a correlation between OxyLite and Vevo LAZR measurements. These experiments were performed on 5 tumor-bearing mice, and we observed similar variations, so it's reproducible. We also performed an additional experiment when inserting the two OxyLite probe inside the same tumor. The first one was inserted in the hypoxic core of the tumor, and the second one was inserted in a well oxygenated area of the tumor. And we also observed similar results when challenging the oxygenation in the gas mixture. We compared our photoacoustic results with histopathology with hematoxylin eosin staining. At an early stage, there is no necrosis, but we observe hypoxia inside the tumor. And with a later stage, we can see necrosis inside the tumor corresponding to an hypoxic area in photoacoustic, but also a non-necrotic area corresponding to an hypoxic area inside this tumor. We also validated these measurements with p-monidazole immunostaining, which highlights hypoxic area on the tumor. You can see in green the hypoxic areas with the p-monidazole staining. And we observed a good correlation between this hypoxic area compared to the photoacoustic measurements. As you can see here, an hypoxic area, and this one, an hypoxic area here, corresponding to this photoacoustic image. So as a conclusion, the OxyLite and the Vevo LAZR system provides a well-correlated data for tumor oxygenation, and the association of these two modalities validates the ability of these techniques to measure the tumor oxygenation variations. And OxyLite provides a strong support to the relevance of in vivo photoacoustic data. P-monidazole immunohistochemistry also validated and confirmed our photoacoustic data. So photoacoustic imaging is a non-invasive modality combining spatial and temporal co-registration and allowing a full 3D mapping of hypoxia inside the tumor. So further experiment could interest on the evolution of hypoxic areas towards necrosis by photoacoustic imaging. So it's relevant imaging modalities to assess the tumor growth and oxygenation. The second study is an ultrasound and photoacoustic imaging of orthotopic lung cancer. First of all, I will explain the place and the limit of CT scan on tumor exploration. CT scan is the clinical reference modality for lung tumors exploration. And thanks to technological developments, it's possible in mouse to perform exploration with sufficient resolution and operationality. However, there is a limit for lung tumor exploration in Onco-Pharmacology because of the dosimetry received by the tumor. This dosimetry can be 3 to 4-fold higher on the tumor than other organs. That's why there is an irradiation effect on the tumor and a potentiation effect when we are testing new therapies. Regarding the contrast, sometimes there is a lack of contrast between tumors and surrounding tissue, especially the liver, so it's not possible to accurately measure the tumor volumes by manually delineating the margins of tumor in the sections of CT images. Another limit on this cancer model is also with bioluminescence, because bioluminescence is a modality depending on ATP and oxygen. So when we are in presence of a highly hypoxic model, we won't have enough oxygen inside the tumor so that will be representative of the tumor burden. As you can see here, the tumor growing with the bioluminescence signal increasing with time, then a decrease in this bioluminescence signal due to the presence of hypoxia. That's why bioluminescence couldn't allow to follow the orthotopic growth of this highly hypoxic tumor model. That's why we wanted to develop a model allowing the lung exploration with photoacoustic and ultrasound. As you know, ultrasounds cannot be conducted in the air. So if you have a tumor inside the lung, it won't be possible to explore it with ultrasound and photoacoustic. That's why we developed a model inserting the catheter in the deep bronchus and in deep lung, so that we have tumor growth in the posterior part of the lung. So it's possible to perform ultrasound as well as photoacoustic explorations on this tumor model. We first validated the method of implantation. We controlled the catheter location by planar radiography, but also the control of the cell deposition with a SPECT CT when using technetium labeled cells, as you can see here, the cells. But also we controlled the early tumor growth thanks to bioluminescence imaging. For the results with ultrasound, as you can see here, the tumor, in the lung tumor, in 2 dimensions, but also in 3 dimensions. We compared 2 different tumor burdens from 125,000 and 250,000 cells, and we observed a difference in the tumor growth measured by 3D echography. And with bioluminescence, we observed a slight stagnation in the bioluminescence signal instead of this tumor were continuously increasing. This is an example of a well-oxygenated tumor. As you can see, a well-oxygenated tumor and an hypoxic, a really hypoxic tumor here. And it's possible to measure with this tumor the hypoxic volume and the whole tumor volume. We compared our in vivo measurements with our 3D ultrasound in vivo measurements with CT scan, and we observed a quite good correlation for this lung tumor model, because it's a bit difficult to measure it with the breathing movements. And we also had a good correlation between ultrasound in vivo and ultrasound ex vivo. We also performed contrast-enhanced ultrasound imaging when injecting microbubbles. As you can see here, the tumor and the tumor, and you can see the microbubbles arriving inside the tumor. So we decided to use targeted microbubbles and compare the expression of VEGFR2 by nonlinear contrast imaging, and we observed a significant difference in the VEGFR2 expression as compared to the isotype control antibody. As you can see here, the parametric images from the isotype control antibody and the expression of VEGFR2 in these tumors. As conclusion, this study demonstrated the ability of ultrasound imaging to detect and monitor the lung tumor growth in vivo. And this approach has the advantage to be real-time and fast while being entirely inert regarding the tumor growth, because it allows non-invasive and non-radiation based investigation. So it's an interesting approach for longitudinal tumor progression investigations in animals when assessing the efficacy of new anti-cancer therapies. And it's also not subjected to disturbances due to appearance of hypoxia as the bioluminescence. So photoacoustic and ultrasound imaging is a relevant imaging strategy to investigate orthotopic lung tumor growth and assess key parameters such as hypoxia or the VEGFR2 expression. The next step will be the comparison between these different modalities, photoacoustic and ultrasound, but also CT and pimonidazole immunohistochemistry, bioluminescence, with PET signals, because when you're using FDG PET, sometimes you can observe an heterogeneity of the uptake of FDG inside the tumor. So it will be really interesting to compare this PET heterogeneity and the appearance of hypoxia inside this tumor. The next example is an anti-tumor efficacy assessment, a photoacoustic and ultrasound imaging study. First of all, I will explain you the prodrug we were using. This prodrug is a beta-glucuronidase responsive albumin-binding prodrug of MMAE. The MMAE is a monomethyl auristatin E, which is a synthetic tubulin polymerization inhibitor. Regarding the release mechanism, There is a cleavage by an enzyme, the beta-glucuronidase, which is located in the microenvironment of tumors. So it allows to release this cytotoxic agent, the MMAE, in the vicinity of tumors. When you inject this product, it will be linked in vivo with albumin. Then, when arriving in the tumor, there will be the beta-glucuronidase, which will cleave the trigger and release the MMAE under its active form only in the vicinity of these tumors. So the aim of this study was to assess the efficacy of this new anti-tumor product, but also to characterize the tumor hypoxic status before and during the treatments. We used 4 different cancer models: the Mayapaka-2 pancreatic cancer model, orthotopically implanted, the breast cancer model MDA-MB331, the human lung cancer NCI-H460, orthotopically implanted, but also the KB human head and neck cancer, subcutaneously implanted. We chose these different tumor models because they were really hypoxic, and some of them own a really poor prognosis, and there is a lack of efficient therapies for some of them. For the imaging modalities, we used the bioluminescence imaging to assess the tumor proliferation. For the tumor volumes, we were using 3D ultrasound imaging, but also CT scan for lung tumors. And the tumor perfusion status was assessed by contrast-enhanced ultrasound imaging, and the SO2 was measured with photoacoustic imaging. For the first cancer model, the pancreatic cancer model, we used 1 IV per week during 2 weeks at 4 milligrams per kilogram. And for these really small tumors, 10 millimeter cube, we observed a decrease in tumor volumes measured by 3D ultrasound as compared to the free MMAE and the vehicle group. Regarding the bioluminescent signals, we observed disturbances due to the presence of hypoxia inside this tumor, an increase in bioluminescent signal for the vehicle group and a decrease in bioluminescent signal, instead of a continuous growth of this tumor. We observed a regression for every animals and a disappearance of tumor for 2 animals. These are the images. We have a decrease in the bioluminescent signals according to a decrease in tumor volumes measured by ultrasound. And for the vehicle group, for example, you have an increase in bioluminescent signals, then a decrease in bioluminescent signals. And you have a continuous increasing tumor volumes for the 3D echography. A former PhD student validated the fact there is hypoxia in the center of tumors, but also at the invasion border of tumors using the pimonidazole immunohistochemistry. But with photoacoustic imaging, we were able to characterize the presence of hypoxic area inside the tumor, and the more the tumor are big, the higher hypoxic status of this tumor it is. So we decided to test again this product on the same model with 1 IV per week during 9 weeks, but on really large and highly hypoxic tumors from 3,000 millimeter cubes. And we observed 92 to 100% of tumor reductions, and we also observed disappearance of tumor for 1 animal. For the breast cancer model, we used 1 IV per week during 5 weeks at 4 milligrams per kilogram, and we also observed a decrease in tumor volumes measured by 3D ultrasound as compared to the free MMAE and the vehicle group. And also in this model, we were able to characterize the hypoxic status of this tumor before treating these tumors. can see here also the bioluminescence imaging with a decrease in bioluminescence signal with according to the decrease of tumor volumes, and also disturbances due to appearance of hypoxia and necrosis on these mice. So as you can see here, the evolution of hypoxia in this breast cancer model, at the beginning you have a really small tumor, 5 millimeter cubes with a SO2 at 48%. Then with time you can see here the hypoxia appearing in the core of the tumor, and for this tumor at 142 millimeter cube you have 35% of oxygenation inside the tumor. So there is a high decrease of oxygenation in this tumor. Regarding the lung cancer model, this animal received 1 IV per week during 5 weeks at 4 milligrams per kilogram. However, we didn't use any contrast agents because we didn't know the effect of these contrast agents on the tumor growth and the potentiation effect it could have with the prodrug. And due to the lack of contrast between the tumor and the surrounding tissues, we used the formula to measure the CT tumor volumes. And we were not able to highlight the anti-cancer effect of this prodrug and this tumor. However, we observed a protective effect on metastasis and the metastasis development from the primary tumor. There were no mice developing metastasis in the treated group as compared to the free MMAE and the vehicle group. In every mice developed metastasis, and some of them died due to this high metastasis phenomenon. On the subcutaneous head and neck cancer model, we used 1 IV per week during 4 weeks at 2 milligrams per kilogram. And we observed a significant difference in the tumor growth measured by 3D ultrasound. We did not observe any tumor reduction, but this difference in the tumor growth. Regarding bioluminescence signals, we observed disturbances due to the appearance of hypoxia as compared to the treated group. And we also assessed the tumor oxygenation during the time course of treatments. We observed a quite stagnation of tumor oxygenation in the treated group as compared to the vehicle group, and we observed a really decrease of tumor oxygenation during the treatment. For the vehicle group, as you can see here, this small tumor with a volume at 94 millimeters cube and SO2 at 42%. Then with time, you can see here large hypoxic area inside this tumor. So at the end of the study, this tumor was only 12% of oxygenation. As compared to the treated group, for this tumor, 108 millimeter cube, you have 30% of oxygenation, and you can see here a relative conservation of oxygenation inside this tumor. And at the end, it's only 22%, but you can see here a higher oxygenation status of this tumor. In order to validate our photoacoustic measurements, we also used non-targeted microbubbles on these mice. And we observed a significant difference for these two parameters, the peak enhancement and the wash-in rate. We observed a significant difference between the vehicle group and the treated group. As you can see here, a tumor from the vehicle group, and you can't see any bubbles inside the tumor. You can see slight uptake of bubbles here, but for this treated tumor, you can see a lot of microbubbles uptake inside this tumor. So as a conclusion, bioluminescence cannot be used as a relevant proliferation biomarker at the time a tumor becomes hypoxic, but it's useful to allocate mice in homogeneous group, but also to control the engraftment, the early engraftment, and to detect the early metastasis. CT scan can be implemented to measure tumor volumes in the lung cancer model. However, we have to be careful about the contrast and also the dosimetry received by the tumor. And with photoacoustic imaging, it was possible to highlight the hypoxia inside the tumor and to accurately map the areas of hypoxia in this tumor. And thanks to contrast-enhanced ultrasound imaging, it confirmed our photoacoustic results. Regarding this product was significantly effective on 3 highly hypoxic cancer models as compared to the 3 MMAE and the vehicle group. And it provides a protective effect against metastasis only in the lung cancer model. So it opens interesting perspective for treating tumors while sparing healthy tissues when you're using this chemotherapy. And photoacoustic imaging is an interesting resource to assess the evolution of hypoxia during the time course of treatments. And it brings a strong support to invalidate the use of bioluminescence imaging for the assessment of therapies when you're using therapies on highly hypoxic cancer models. So as a discussion, considering the crucial effect of hypoxia upon the chemosensitivity toward necrosis, toward anti-tumor drugs, the use of hypoxic tumor models would provide a better predictivity for the translation to clinical research. And because ultrasound and photoacoustic imaging are able to evidence the effect of treatments on hypoxic tumors, this modality would be of great interest for the assessment of therapies targeting intratumoral hypoxia. The last study I will present is a bimodal strategy for the sentinel lymph node exploration based on fluorescence and photoacoustic imaging with spectral mixing. In the clinical practice, to detect the sentinel lymph node for breast cancer, there is you have to co-inject a blue dye and a radioactive tracer inside the drainage area of the tumor in order to identify the sentinel lymph node. Then when the lymph nodes are identified, they are excised from the body and for analysis. So the aim of photoacoustic investigations are to provide a non-invasive and non-radioactive method to detect the minimally invaded lymph node. We also used IHCG as a photoacoustic contrast agent because the absorption peak of the IHCG is around 800 nanometers and there's less disturbances due to hemoglobin, and it is also clinically approved. We validated the detection of the lymph nodes with 4-pro injection of IHCG in rats. We injected the IHCG in the 4-pro, and then with the drainage area, with the drainage, it will go through to the lymph node. As you can see here, the axillary lymph node of the rat. And this is a kinetic of washing of IHCG inside this lymph node. You can see here appearing the IHCG inside the lymph node. We also validated the use of methylene blue, which is a blue dye, also detectable with photoacoustic imaging. As you can see here, the washing of the methylene blue inside the sentinel lymph node. And we also wanted to compare, to use co-injection of IHCG and methylene blue thanks to the spectral mixing with photoacoustic signal. As you can see here in blue and green, in blue the methylene blue, and green the IHCG, and you can discriminate the signal from methylene blue and IHCG. This is a fluorescence image of this axillary lymph node. We also tested on mice models the use of IHCG injection into the ear of animals in order to highlight the cervical lymph node. As you can see here, the cervical lymph node, and here the signal from ICG. And when we are using the unmixing tool, you can have this lymph node highlighted with ICG. This is a different view, a 3D render showing the lymph node and lymphatics. And here is a merging of 3D render on the black and white image. We then developed a model of lymph node invasion. We injected the cells in the forepaw of the rats and the breast cancer cells, and we controlled the invasion by bioluminescence imaging. As you can see here, the signal from the lymph node. And we also validated this invasion using a targeted dye, RGD mimetic dye targeting integrins linked to the cyanine 5,5, and we injected this probe 24 hours prior to access the lymph nodes. As you can see here, the invaded lymph node here as compared to healthy lymph nodes. We also validated this model on mice. As you can see here, the signal from the primary tumor in the hand of the animal, and you have here the sentinel lymph node. And when the lymph node is excised, you can see here bioluminescent signal and the fluorescent signal. And compared to healthy lymph nodes, you have here the signal from the invaded lymph node. And after a spectral mixing with fluorescence, you have this signal on the invaded lymph node. So as a conclusion, fluorescence should be for some of tumors a successful alternative for the in vivo detection of sentinel lymph node as compared to colloid, technetium colloids. And photoacoustic coupled with ultrasound imaging allows a higher resolution molecular imaging for dynamic lymphography of ICG. So the next step will be targeting ICG on tumor cells in order to detect the invasion of the lymph nodes. So we would like to use RGD mimetic labeled with ICG targeting integrins alpha V beta 3 and alpha V beta 5. And we also would like to use cetuximab labeled with ICG targeting EGFR. This is a really preliminary studies. We don't have enough time yet to perform images on the detection of sentinel lymph nodes with the probe injected IV. But we already validated the detection and the biodistribution of a labeled antibody on a primary tumor. This is a tumor. This is the photoacoustic signal before IV injection. And this is a signal 1 minute post IV injection of the cetuximab labeled with ICG. And 24 hours later, you have here the signal from the cetuximab labeled with ICG. So we can also compare this biodistribution pattern to the power Doppler or oxygenation, but also the contrast. So the next step will be to highlight the invasion of the lymph nodes with this kind of invasion models. So as a general conclusion, I'll say hypoxia imaging is really important because it appears really early during the tumor growth, and it's involved in the choice of therapeutic strategy for the patients. And specific biomarkers imaging is also really important thanks to the use of targeted contrast agent, because it will provide better strategies for the management of patients and also to practice a more personalized medicine. But there is still a need of dedicated photoacoustic contrast agents. And to me, photoacoustic will become an essential imaging modality in the near future. I also added this last slide on the Vevo LAZR-X because every experiments you've seen were performed with the Vevo LAZR, and it would have been great if we could use this Vevo LAZR-X because of the higher energy of the laser, so it allows to cross more organs and more tissues, so it would have been interesting to use it for pancreatic orthotopic cancer models. And also for dynamic studies, because of the higher tuning speed, it would be we could perform faster spectral acquisitions. But also regarding the biodistribution of contrast agent, thanks to the whole body imaging, it would have been easier to detect the biodistribution of contrast agent, of labeled contrast agent. It's also time saving because it's faster, so it might be really useful to perform scans on more animals and to have more parameters in the same animal during the same anesthesia. And thanks to the new wavelength range, it opens new perspective for new endogenous contrast agents, but also exogenous contrast agents. So if we have the funding to get this new LAZR-X, I think it might be great. I'd like to thank my PhD directors, Stéphanie Lerondel and Alain Epap, but also the whole VisualSonics team, and thank you for your attention.